hopefully we can get done with this lecture and our thoracic lecture that we were supposed to do today, to try to stay on track. If I know it's hot in here, so I at least want to do our, like, you know, 2 50-minute sessions. If you guys are really not having it after that, and not just from boredom, right? Please let me know. We'll come up with a good game plan. But let's try to get through as much of this as we can so that we can stay on track for the rest of the semester, okay? All right, so I believe we were talking about toxicity last time, yesterday. Yes? Depends. Hopefully as quickly as we can, okay? I don't think we'll get, like, I don't think we'll have to stay till 5. We'll definitely be done earlier than that, okay? But let's just push. All right, toxicity. So we talked about yesterday the max doses for both lidocaine with and without epi and bupivacaine. Okay, why do we do that? Again, because we don't need to give any more anesthetic than we actually need, right? We want to have good pain relief and numbing, but we don't want to necessarily cause these toxicities. So when we're talking about, like, more generalized anesthetic, these are the types of things that we can kind of look at. But it can also happen with any type of anesthetic we put in the patient's body, whether it's localized or not, okay? So if you have somebody who is hyperventilating, so hypercarbia, basically that decreases the CO2, and if you give benzos, it can actually, it can precipitate a seizure, and we give benzos to try to help bring them out of that seizure, okay? With cardiovascular symptoms, if they develop hypertension, we give IV fluids, and any arrhythmias, we treat per the ACLS guidelines, depending on what type of arrhythmia it is. And then malignant hyperthermia. This is one of the most important things on this slide. Okay, malignant hyperthermia can kill people, just like the other ones can too, but this is something that is more frequent. Basically, it is a rare inherited condition. So 1 out of 50,000 people this will happen to. Most commonly, it happens with the volatile type of agents as well as succinylcholine. Really, really happens more commonly with succinylcholine, okay, which is a paralytic. And what happens, it actually shoots our bodies into a hypermetabolism state. You have fever, you have tetany, meaning that rigidity, which then causes hyperkalemia, okay, which we all know what hyperkalemia can cause, the arrhythmias and heart contractility disorders, which can then lead to death. So we try to avoid this and try to treat it. This is the one thing that we give dantrolene to. So if you see somebody who has malignant hyperthermia type of situation, they're just been put under generalized anesthesia, and they, the anesthesiologist or the CRNA are saying, yeah, no, they're starting to have a fever, they're a little bit, tachycardic, they're hypotensive, the normal hyperkalemia type symptoms, like the severe type symptoms. This is when we give dantrolene, we rapidly cool, we try to bring them out of that anesthetized state, okay? And then we try to make sure that they don't ever get that volatile agent that they've got to prevent any further malignant hypothermia in the future. Okay, this is why we ask every single person that we put under anesthesia, have you had any issues with anesthesia in the past? Okay? All right. Just some go-bys for the local anesthetic administration. Remember, we use this for more so minor surgeries, laceration repairs. You insert the needle, aspirate, and then instill the whatever you're using as you draw the needle out. Okay, you want to try to attempt as large area coverage as you can with one puncture. Okay, so when we're doing like a digital block, right, we're going to go in on one point, go down to one side of the finger, and then before we actually take the needle all the way out, we're going to actually in the skin turn the trajectory, go across the top of the finger or toe or whatever it is. Okay, then where that we actually insert the needle for the other side of the nerves, that's already been anesthetized by one injection. Does that make sense? Okay. And then Sequela, so we give the anesthesia or the analgesia, whatever it is. It's going to cause vasodilation in the skin. In the tissues, it's going to have loss of sympathetic tone. You're going to have loss of pain or temperature, loss of pressure, and then loss of motor function. Okay. Some, like lidocaine, you still be able to move it. Most of the locals, you're going to be able to still move it, but you're not going to be able to feel it. They may still feel pressure, so when you are doing a laceration or minor procedure, you still tell them, hey, let me know if you have pain, but you can expect to have some pressure. You're still going to maybe feel me pushing and pulling. You may still feel the instrument in there with some pressure, but you're not necessarily going to feel pain. If you do, let me know so I can instill more local anesthetic. Okay? All right. Why is epinephrine added to local anesthetics? Think back to yesterday. Who wants 1? Who wants 2? Who wants 3? 4? 5? It is 2. Prolong the duration of action. Remember, it vasoconstricts that area. Okay? And with that vasoconstriction, it stays in that local area longer. Alright, so peripheral, regional blocks. Okay, so this is basically we're injecting that anesthetic near a peripheral nerve. So we can do digital blocks, rib blocks. Okay, there's a bunch of regional things that we can do, depending on where we want to do. If we want to do like just one injection and do a wide area versus a local. Okay, you have to evaluate the neurovascular status prior to injection. We try to remember that like the digital nerves, so on the dorsum of the foot. So if you just inject the top of the toes, you're never going to get those digital or the dorsal, sorry, other way around. Dorsal is the top of the foot. Jesus. So if you only lidicate or anesthetize the bottom of the foot, the top of the nerves aren't going to get any of that installation versus the fingers, right? They run along the palmar surface of the hand. So if you only inject the top, the bottom is not actually going to get any of those nerves. Okay? And if you are doing a deep space or a joint, you're doing it under sterile settings. Okay? These are just some areas in which we can do regional blocks. Okay? We try to isolate those nerves, whether it's by, normally it's by ultrasound. Okay? All right, going into the central nerves, or central blocks. Okay, there's 2 main ones. There's a spinal and an epidural. We normally use these if we're doing lower abdomen, lower extremity, GU, GYM procedures that we don't want to actually put the patient under general anesthetic. Okay? So epidurals, like I said yesterday, are what we use for pregnant labor and delivery. Okay? We can put a catheter in that epidural space. We can continuously infuse a small amount of the anesthetic. They can still move their legs and still feel pressure, but not pain. Okay? Normally managed by the anesthesiology pain service. Okay? Some hospitals do not have an actual pain service, so it's just the anesthesiologist or the CRNA. When I say CRNA, does everybody understand what that is? Does anybody not know what a CRNA is? So, a certified nurse anesthetist. Okay, so they're registered nurses who go on to school. So like nurse NPs is basically an anesthetist nurse. Okay. So for spinals, they go into the subarachnoid space. Okay, so you'll see there's the green is the spinal fluid, spinal canal, where the spinal cord is located. So this needle goes into that space, almost like a lumbar puncture. Okay, but instead of taking fluid out, we're putting fluid in. It's a one-time shot. Okay, we do not leave catheters inside of the spinal canal. We can do it multiple times over the course of a few days if it wears off, but most of the time it's long enough acting that it stays for a decent amount of time to do whatever surgery or procedure we need to do. Okay? It blocks both sympathetic, sensory, and motor. So when they have spinal, they can't move. Okay? Unlike an epidural, they can still move. They can still wiggle their toes. We still don't trust them walking. Okay? But with a spinal subarachnoid block, it completely blocks their motor function. Okay, the most common complication is that post-spinal headaches, just like with the lumbar puncture. Okay, and we treat that with an epidural blood patch. Okay. Just know the most common complication from a spinal block is a headache, post-procedural headache. Okay. All right, then going into epidural. So this is the space still within the spinal foramen, the vertebral foramen, but not necessarily within that subarachnoid space. It's outside of the derma. Okay, so you have the spinal cord. The red is where that spinal subarachnoid space is. That's where the spinal goes. So just outside that, they're not actually going into the spinal canal. This is where we can leave that catheter. This is where we can slowly instill that anesthetic. Okay. Block sensory, but not necessarily motor. So it's very good for rib fractures. And if I have a person who's got bilateral rib fractures, multiple rib fractures, and they're not taking really good breaths, they're not coughing, to help prevent pneumonia, we will instill an actual epidural catheter during their first initial few days after their injury, and we can actually get them back to, not normal, but back to better pain relief. Okay? And again, this is what we use for labor and delivery. Okay? Positioning. Doesn't matter which one we're doing, whether it's the spinal or epidural. Okay? We either do it at a lying position or that sitting, hunching, holding a pillow. Okay? We want to try to open up. And when I say laying on its side, they're kind of in that fetal position. We're basically trying to open up that spine, those spinal processes, enough that we can get that needle through. And this is just a good outline of, if you're looking at a C5, okay, that's cervical or clavicles, T4 is around the nipples, and T10 is around the umbilicus. That's just a very good basic. If I were to tell you, we put this in at the T10 level, where do you think that anesthetic would start? Around the umbilicus canal. Okay? That's just another good picture to try to really get it through, like, where these actually go in terms of in relation to the spinal canal and spinal cord. All right, 31-year-old G1P0 female comes 38 weeks in labor. Spinal anesthesia technique is planned for delivery. In planning for anesthesia, you decide to review the spinal cord anatomy in this patient. What spinal level would you expect the spinal cord to terminate? Think back to anatomy. Where does the spinal cord terminate in the spinal canal? So 4? Yes. Good. Yep. L3, L4, that's why we normally go L4, L5. You still have the cauda, right? You still have the cauda equina, but you don't have that actual cord, so it's less likely to actually get stuck or stabbed. All right. Acute complications, central nerve blocks. This goes pretty much for both of them. Okay. Big one is hypotension, having that neurogenic shock. Okay. A lot of times it will be precipitated by a reflex tachycardia. So your anesthesia, you're getting ready to start your procedure, and all of a sudden she goes from, a really low or normal heart rate 80s up to 130, right? You can anticipate that her blood pressure dropped, and we just didn't catch it yet because that's her compensatory type of body function to try to increase her blood pressure. Okay, so her heart rate jumps as her blood pressure drops. Okay, if we're doing a high spinal, okay, say we're doing more thoracic, we can get bradycardia, hypertension, and arm tingling depending on the area. Okay, respiratory distress is a big one. If respiratory distress occurs, we have to ventilate. We can give intravenous naloxone to try to revert, depending on what type of medication we instill. And then a good one to know that if you're around C3, C5, that's where the diaphragm is innervated. So if you're above that, you can pretty much know that their respiratory depression is going to happen. And chronic aquinas syndrome, just like I was talking about, okay? If we do, you know, an L5 or really if we go a little bit high at like L2, L3, or anywhere above that, we can see this chronic aquinas syndrome kind of start, where you have that bowel and bladder function, the saddle anesthesias, that kind of thing. All right, later complications. So these are acute. This is when you first instill the medication. Okay, these are the things that you need to be worried about acutely. Then, if it's been there for a minute, we have to worry about urinary retention. It's the most common complication of any central nervous block. Okay? If your bladder isn't getting, if you're not getting any sensory or motor to your legs, you're probably not getting any sensory or motor to your bladder as well. Okay, so urinary retention is a big one. That's why we bladder scan and do those straight catheterizations if we need to, or put a Foley in to help kind of get them through whatever they're going through. Okay, spinal headaches, again, big one. That's basically the CSF leaks out, and so you have a drop in that CSF pressure, your head starts to hurt. That's where we do the blood patch to try to fix. Okay, and then epidural hematomas compresses that spinal cord. You really suspect it if someone's anticoagulated, which is why a lot of times if we are doing these planned spinals, okay, if they're on an anticoagulant, and sometimes, depending on the anesthesiologist, even antiplatelets, we have them hold it for a specific amount of time. Okay, so if they're on Lovenox, we have to hold it for a good 24 hours before they're even willing to do a block. And then we wait 12 to 24 hours before we restart their anticoagulation to try to avoid these epidural hematomas. Okay. All right, you have a 34-year-old G3P1 female undergoing a cesarean section delivery under spinal anesthesia. 8 minutes after supine position, the patient begins to complain of nausea, apologizes that she's about to vomit. You look in the monitor and the heart rate is went from 72 to 125 within 30 seconds. So what is the most appropriate next step? Who wants 1? Who wants 2? Who wants 3? Okay. Who wants 4? 5? No 5s. At least you didn't say 1. Okay. First thing we have to do, okay, we have that reflex tachycardia. We have to give her a pressor. Phenylephrine is a great one. It's a short-acting pressor, so we have to bump up her blood pressure. Okay, we may still give her a Donzotran or Zofran. Okay, we may still give her that, but we have to get her blood pressure up in order to fix this neurogenic shock that she's starting. Everybody understand that? All right, conscious sedation. This is monitored anesthesia care. Okay, this is kind of what we call twilight. Okay. It's a depressed level of consciousness, but they're normally still breathing on their own. Okay, we use this a lot for endo cases and colonoscopies, so they don't remember what we did to them. Okay, but they're still kind of there. Okay, so provides analgesia plus anxiolytics. Most commonly we use propofol, fentanyl, or propofol and Versed. Okay, propofol is a great anesthetic. Okay, it really helps that amnesic type of response, as well as ketamine is another good one. Okay, so we use those a lot. Bronchoscopy, we give ketamine a lot to kids. Okay, and when we are doing either close reduction fractures, or so that everybody understand what close reduction fractures. Basically, you have a closed so it didn't go through the skin, and you're trying to reduce a fracture in the ER. Okay, we put them under conscious sedation, that twilight sedation, so they don't really feel that pain of popping it back into place. So it's not just for fractures, but it's also for dislocations as well. Okay, when we really want them to relax in order to get it back into place. All right, patient safety. When we do conscious sedation, the crash cart must not be next to the patient every single time. Okay, if you have a different type of hospital, when I was at Cook, we had a crash cart, an airway cart, a procedure cart. all sorts of carts, right? So we have the airway cart and the crash cart next to every single person, or at least very close to their bay, before we started conscious sedation. We made sure that whatever nurse was on that patient, it's a one-to-one care. So if they had any other patient, another nurse would take care of that other patient until this conscious sedation patient came out of anesthesia. Okay? If you do not have that type of dedicated nursing staff, then most of the time, this happens in the OR. Okay? Or in the ICU setting. Okay? Normally we only use it for class 1 and 2 ASA patients. If they are higher than that, then that's when we go to either the ICU or the OR. And then we try to make sure that they are MPO prior to the procedure for at least 4 to 6 hours. Okay. All right. General anesthesia. What are our goals of general anesthesia? Okay. We want to get pain control. We want to make sure that the patient forgets, that they don't remember anything, and that we have maximum muscle relaxation. There's 3 stages of anesthesia. Induction, meaning the time of onset of that push of propofol, to effective surgical anesthesia. Okay? That maintenance is the same throughout the case. They're not waking up, they're not wiggling, they're not, trying to get off the table. Okay? That's why we have CRNAs, that's why we have anesthesiologists who stay at the head of the bed so we can keep them asleep. Okay? And then recovery and emergence. Depending on what the procedure was, I mean, we don't like to have people just pop awake. We like to slowly bring them out of anesthesia, especially if we were doing any sort of like reconstruction type surgery with a lot of sutures in their belly, or it's under a lot of tension. We don't want them waking up coughing or swinging, right? People can get very aggressive coming out of anesthesia, which again is why we ask people beforehand, hey, have you ever had any issues with anesthesia? We ask, okay, great, you've had anesthesia before. Did you wake up calm? Did you wake up swinging? So that we can be prepared. Okay? So intraoperative management, again, same thing. We have that induction anesthesia, the monitoring, and the recovery. Okay, they're not going to necessarily recover fully when they're in the OR. We're going to at least get extubated 80% of the time. Okay, and then they get moved to the PACU, which is the post-care anesthesia unit, where they have dedicated nurses to help them kind of wait it out while they wake up before they get either discharged or sent up to the floor. Again, some induction agents can cause extreme hypotension. So a lot of times, say we have a trauma patient who is very critical, okay? They have some sort of preload issue, okay? Maybe back to cardiology, preload issue. If we give them propofol, they could actually drop their pressure enough that they go into cardiac arrest. So in that case, we normally have everything set up around them. If we think that that's going to be the case, like we are down ready to cut as soon as they go and be induced to anesthesia. So therefore, if they do go into cardiac arrest, we can act right then and there versus, oh shit, you're going into cardiac arrest and we still have to get down. Okay, so if we can anticipate that any little bit, we will. Again, anesthesia maintains that airway and breathing. They're intubating and then ventilating. There is a difference between ventilating and oxygenating, but we'll talk about that later. Okay? And they're the ones who are going to be actually taking care of all the blood products, all the fluid products. They're going to be watching that urine output and basically checking the vitals every however often they need to. Okay? They're going to also prevent hypothermia. They're going to be keeping an eye on us and telling us, hey, your patient's getting cold, maybe we need to hurry up, or whatever. Okay? So there's a lot of things happening just at the head of the bed that affects the entire room. Okay? And then in terms of intubating, which I'm sure you guys will learn more about in EM, so I'm not really going to talk about it, but you have direct visualization. Okay, actually looking, when you say DL, like that's the actual camera, you're actually looking at, not the camera, the little, I know what it's called, just, yeah. But anyway, there's a thing with a light on it, and you can actually see the vocal cords versus the glide scope. It has a little camera on the end, so you're actually watching the screen and putting the tube in that way. Okay, so there's a difference between direct and indirect. And an LMA, this guy on the side, okay, it doesn't actually go into the trachea at all. It doesn't go through the vocal cords at all. It basically sits at the junction of your esophagus and your trachea, okay, and it closes off like this lip. The very tip kind of sits actually in the esophagus, so it blocks it. And then this opening just kind of goes over the tracheal opening. Okay? So this is not a definitive airway. A definitive airway, in definition, actually has to pass the vocal cords. Okay? Alright. Alright. There are 3 medications on this slide. I want you to know them. Okay? The more you know them now, the easier phase 2 is going to be, the easier life is going to be when you get out to the field. Okay? Basically, these are your conscious sedation and your general anesthetic type of medications. There are way more than just 3. Okay? So this is just a good chart of, these are 3 that we use more commonly than not. Okay? Propofol, ketamine, and etomidate. I want you to know the kind of the milligram per kilogram ranges. Okay? They're very, very close. So normally for propofol it's 1 mg per kg. Ketamine, again, 1 mg per kg. And then etomidate, we normally do 0.2 per kg, mg per kg. Okay? But knowing those and then knowing how long they work and how fast they work. Okay, so if you give someone etomidate within 4 minutes, they're going to stop breathing. Okay? Propofol and ketamine, if you give enough. Okay, we can use both for induction agents. Ketamine more so, I mean, we can use them both for conscious sedation as well, but if you give enough of it, it will actually suppress the respiratory drive and then be an induction agent versus a conscious sedation. Okay? All right, so general anesthesia, reversible state of CNS depression. Okay, it results in analgesia, so pain relief, amnesia, unconsciousness, sensory and autonomic reflex suppression, and in many cases reflex or muscle relaxation. Okay, if we need complete relaxation, we want a paralytic. But if you give enough fentanyl, they're going to be floppy. Okay, you give enough propofol, they're going to be floppy. Okay, but we want to do a balanced anesthesia. Okay, we want to make sure that we give enough to get these nice properties, but not enough to push them into hypotensive, into a neurogenic shock or a cardiovascular shock. Okay, and we want to be ready. Okay, but if we can give the least amount of these medications to get the maximum amount of depression, everybody's happy. Okay, when you start giving, if you don't understand these doses and effects and their side effects, right? If you give propofol, the number 1 thing is hypertension. And for ketamine, there really is, it actually increases their blood pressure, heart rate, right? The difference between like propofol and Precedex, okay, Precedex doesn't have as much effect on the heart and the blood pressure. Okay, so if you have somebody who's already hypotensive, maybe we don't go with propofol. Okay, or we use a low dose of propofol and maybe more Versed that doesn't have as big of an effect on the blood pressure and heart rate. Does that make sense? Kind of? Okay. 5 benefits of anesthesia, again, kind of the same thing. Okay, but just remember, general anesthesia are not paralytics. They have their own class. So succinylcholine, etomidate, vecuronium, or not etomidate, vecuronium, rocuronium, all of those are paralytics. Okay, so we give the induction of anesthetic first, propofol, ketamine, etomidate, and then once they're adequately sedated, then we give paralytic if we need to. All right, mitigating complications of general anesthesia. So if they become hypoxic or they have a cardiac event, obviously they're already under general anesthesia, so they are continuously monitored by the anesthesiologist. Okay, we start with ACLS medications and Crocart. If they aspirate, okay, this is why we're trying to prevent aspiration. Okay, so that's why we make NPO prior procedure or surgery. We may use anti-acids or like PPIs, H2 blockers if we need to. It really just depends on what surgery we're going to be doing. Okay, and then this is why we use cricoid pressure during this intubation, that Selleck maneuver, trying to close down that esophagus to have less likely of a chance of stuff coming up, and it really gets the vocal cords. If their vocal cords are more anterior, we can push them into view. Okay, and then nerve injuries, we have the patient make sure that they're comfortable, that there's no cords running underneath them, no lines running underneath them. We're not hyperextending joints. We lubricate and then tape the eyes closed to prevent ulcers. All right. Which intravenous induction agent is most likely to cause hypotension due to vasodilation and myocardial depression?
3.
Who wants 1? Who wants 2? Who wants 3? Who wants 4? And a 5th? Yeah, 5th. 5. Great. So it is propofol. Number 3. Okay? Has the highest rate of hypertension of all of them. All right, post-anesthesia care unit, I already talked about this a little bit. So this is a recovery room for outpatient procedures. If they go to the floor, okay, so it's not necessarily an outpatient procedure. Say they want to stay the night, they have to stay for a couple days to monitor them, but they're going to the floor. They go here first, and then once they fully recovered, they go to the floor or they go home. Okay? Normally we want all of these things. Stable out of bed for 30 minutes, stable vital signs, they're fully responsive and oriented. They can ambulate, their pain and nausea is controlled, and they're peeing and tolerating oral intake. Okay, basically you need to be able to walk to your car. You need to be able to eat, pee, walk. As long as you can do those, you can go home. Okay? If we suspect that you're going to be in an ileus and we need to watch you for a few days, then we'll put you in the floor. So you don't necessarily have to have waiting or ambulatory, but we like to have you be fully responsive, okay, before we move you up to the floor and have stable vital signs. If they're going to the ICU, they normally will bypass the PACU and go straight to ICU. Okay, PACU is normally floor or med-surg level nurses. Okay, all right. Writing discharge orders saying they're actually going home. Okay, we already talked about follow-up instructions. What do they need to do in order to be successful in getting their wound to heal? Okay, what follow-up appointments do they have? Okay, if they're following up with you in your clinic, in the surgery clinic, whatever, make sure that you schedule that appointment prior to them leaving the hospital. And that they know that when that appointment is and where it is. Okay, they showed up at the ER and are following up at a clinic that's 2 floors down on the other wing. Okay, make sure that they know where that other clinic is. Okay, they're going to show up to the ER and be like, I'm here for my general surgery appointment. Which just happened. Okay? Making sure that you dictate to them what their limitations are, what their restrictions are. Okay, it's not just don't bathe, but maybe you did something that you don't want them lifting anything heavy more than 5 pounds. You don't want them standing for long periods of time. Okay? And then discharge summary in hand. The patient has to have the discharge summary in hand and understand it prior to them leaving the hospital. Okay? Normally, especially under general anesthetic, if they, even though they appear to be coherent and awake and conscious, right, following directions, we still want them to be taken home by a reasonable adult chaperone. Okay? If someone had just gotten even conscious sedation, we normally don't let them drive themselves home. We're trying to prevent accidents. Okay? So making sure that they have a chaperone in order to take them home or put them in a taxi, which I've done before as well. Okay? If any of these things cannot be met, even if, like, say we were really thinking this is going to be an outpatient procedure, and they were going to go home from PACU, if they can't meet these things, we're going to admit them to the hospital. They just want themselves at least a night stay to recover from anesthesia, especially if they don't have anybody to go home with. Just trying to do patient safety. All right, 45-year-old male developed hypercarbia, muscle rigidity, and rapid rise in temperature during surgery under general anesthetic. What is the most likely diagnosis? You think just 1, 2, 3, 4, 5. Okay, 4. That is that malignant hyperthermia. All right. Any questions on this? You want to take 5, 10, or just push?
Push.
Push. I'm bringing push. Push. Okay. Moving on to thoracic then. All right. I'm going to get through all that. Okay. So, I'm going to start to try to do this on every PowerPoint. If there's a specialist that you may need to know about, for obvious reasons, we're going to go through them at least so that you have them in a slide deck somewhere. Okay? So, pulmonologist, doctor specializing in the lung, cardiologist specializing in the heart, cardiothoracic surgeon are not a pulmonologist or cardiologist. It is a surgeon that specializes in thoracic and cardiac surgeries. Okay, you can have a thoracic surgeon and you can have a cardiac surgeon. Okay, and then you can have a cardiothoracic surgeon. There's 3 different types. Okay, but yeah, you also so you remember the interventional radiologist. There are also interventional pulmonologists. Okay, you have if you were to generalize it for GI, you have the interventional gastroenterologist. Okay, they're like all GI docs. And some general surgery docs can do endoscopes and colonoscopies and that kind of thing. But if they're specialized in GI procedures, such as like cauterization, clipping, like the ERCPs, biopsies, EUSs, they're going to be more of an intensivist type of, or interventionalist versus just a normal pulmonologist or whatever. Does that make sense? So there are different levels to these specialties. Okay? When you talk about critical care intensivists, there's actually 3 different types. Actually, probably 4 or 5 different types, but these are the 3 we're going to talk about. So we have the medical critical care. Okay, they're going to be in your medical ICUs, your maybe in neural ICUs, but you may actually have a neurologist. Surgical ICUs. Okay, they're going to have your surgical critical care specialists. They're most likely a surgical. Like a trauma fellow, meaning they went through a 1 to 2 year fellowship to become critically care boarded. Okay, so they are specializing in surgical critical care cases. Okay, and then you have the pulmonary critical care intensivist, which is their pulmonary doctors who went to fellowship to become critically care fellow board certified. Okay. Okay, respiratory techs, they are specialists, so they're not doctors, they're not nurses. They go to specific respiratory tech school. Do we have any respiratory techs in here? No respiratory techs? All right. Sometimes they get 1 or 2. So respiratory techs, they're specialists. They primarily do the therapies of the lung. So pulmonary toilet, we can do, they take care of the vent. They are basically specialized in ventilators, okay? But they support lung health. Okay? And then when I talk about pulmonary toilet and chest physiotherapy, basically it's either vibratory type of therapies or giving them special inhalations that the doctors or providers write for them, but they're the ones who are actually doing it with the patient. Okay? All right. Anatomy review. So, this is the rib cage. We have the rib, okay? And then we have all of the 3 muscles, the internal, external intercostals, and the innermost intercostal muscle, okay? When we do like chest tubes and we want to do rib blocks, okay, or it's kind of hard because we never go underneath the rib. Like if we inject the rib, we don't ever go under because we're trying to avoid this neurovascular bundle, okay? We go above. Okay, but you still have to make sure that you actually anesthetize the entire area to help not have it hurt as much. Okay, but just remember that the neurovascular bundle for the ribs follow the underside of each rib. For the lungs, again, this should be review. On the right, we have 3 lobes. On the left, we have 2 to accommodate for the heart. Okay. Biggest thing, you have the visceral pleura, okay, in purple. That is what basically think of the organ, okay? It envelops the actual lungs. It is insensate, so it does not hurt. Does not have any sensatory type of properties. We have the pleural, parietal pleura. This is the lining of the inside of the rib cage, okay? It does have actual sensatory. It is innervated. It does have sensory nerves. Okay? This is why rib fractures. This is why any procedures to the lung or to the chest actually hurts. Okay? And then you have the pleural cavity, which holds the where you get like pleural effusions, which we'll talk about, but where a little bit of fluid is, so that your lungs slide nice and smooth against your rib cage. Okay? All right. Really in depth. Okay, if you're going to do a cardiothoracic type of surgery rotation, I would know this, but it is just good review. Okay, just good review. All right. Physiology. I am not going to go through the actual physiology of why lungs do what lungs do. Okay. The biggest thing I want you to take away with is the pleural fluid is normally low in protein. Okay? When you have disease states that actually increases that protein, okay, you can actually have shifts of disease states, okay, that basically leads to the normal reabsorption of the pleural fluid to not happen, okay, which is why we get pleural effusions most of the time. Okay? I would also, does everybody understand the difference between ventilation and oxygenation? Remember that from like 3 semesters ago? Yeah? Okay. As long as you kind of understand that, we can talk about it offline if you don't. But that's a good concept to try to remember when we are going through cardiac or thoracic stuff. Okay? All right, quickly, we're going to go through chest radiographs just as a review, making sure that you hit A through I when you're actually looking at a chest x-ray, okay? When you're looking, make sure that you know which way the patient is facing you, whether it's PA or AP, whether it is a lateral, oblique, okay? Make sure that it's the right patient, okay? Always make sure that your lefts and rights, or at least one of them are identified, to make sure, right? If you're looking at a PA, the left should be on the right side. If you're at an AP, your right should be on your right side. Okay. All right. Everybody remembers lung markings. Okay. Fluffy, cloud-like daisy. You're going to have interstitial lung disease. You're going to have more particles. Okay. It's an airspace. Fluffy, cloud-like daisy. Bones are going to be more white. Okay. Air is black. That cardiothoracic ratio we want to be less than 50% of the entire chest. Okay, so if you move this heart, it's less than 50% of the chest cavity. All right. Again, normal lung appears black. When lung becomes whiter, it's something happening. Okay, it's either lung infiltrates or bruising, like contusions, or it could be high lymph node enlargement, it could be cavitation, it could be a mass, it could whatever, okay? But if you have nice, you can have a little bit of vascular, that you can see, like, right, that's how we know that the lung is up, but this is normal, right? If there's anything that becomes hazy in those areas, that's when it becomes a problem. When we look at hemidiaphragms, that is one side of the diaphragm or the other. Okay, so this is the right hemidiaphragm, that's the left. On this side, right, left hemidiaphragms. Okay? We're talking about the whole thing is just a diaphragm. And again, just like we talked about last block, we're looking at those diaphragms, or the heavy diaphragms, to look for those air, diaphragm, or intraperitoneal air. Okay? We're looking for effusions, foreign bodies, great vessels, gastric bubble, hilum, and mediastinum, and basically what is your impression, right? This is all review. This should all be review, correct?
Yes.
Okay, good. Moving on. Okay, this is just a good review of when you're looking at the lateral, what can you see? Okay, you can review that on your own. All right, moving into actual pathology. Okay, 3 minutes, that was great. All right, so pleural effusions. Okay, this is basically where you have pleural fluid building up in that pleural space. Okay, so it's between that pleural and visceral, or parietal and pleural visceral. Okay, where we normally have a little bit of fluid, now it becomes a lot. You're going to have this meniscus sign. Okay, so this lung, pretty normal, maybe over a little hyperinflated, but you have this meniscus sign. Okay, that is fluid that is making it so that we cannot see the rest of the lung. So like this bottom picture looks very nice. You can see those claustrophrenic angles. Sorry, claustrophrenic angles. Okay, the other side, they're nice and pointy. Okay, when it's not there, you can most likely say that there's an effusion, even if it's a small one. Okay, and don't forget that just like with everything else, like with the fluid and air in the stomach or in the belly and the intestines, it is still gravity dependent. Okay, so if you lay down, that fluid is going to follow gravity and is actually going to have that, instead of it being a meniscus sign on the bottom, it's going to actually shadow more of the lung on the side that you have more fluid. And then if we have fluid that is purulent, what do you think it would be called? Huh? Empyema or a pyothorax, PYO-thorax, okay? Or purulent effusion. All right, pulmonary edema. So this is fluid built up or inflammation inside the lung, okay? This is not outside the lung like the effusion. This is actually fluid building up inside the alveoli. Okay. When we think of cavitation, we see these nice fungal balls here. Okay. So these are circular. They will look different than like a bleb, okay, which we'll see in COPD emphysema. Okay. They're actual like circular. They may have a fluid level. They may look really schmutzy in there and just gross. Okay, depends on what is causing those cavitations. It could be TB. It could be sarcoidosis. It could be whatever. Okay. It could be an infection. But that's the difference between cavitation, pulmonary edema, and pleural effusions. All right, what do you think is happening here? Non-trauma patient, what do you think is happening? Well, is it a cavitation, is it a pleural effusion, or pulmonary edema?
Edema. Could be an
Okay. Is there a sulcus sign? No. So it's probably not pleural effusion. Okay. Can you see cavitations? Can you see nice round lesions?
No.
No. So it's probably either a pulmonary edema, contusion, if there's actually trauma. Okay. What else can you see on there? Is there anything else that you see on this x-ray that is good to know, that may lead you to what this actually is in terms of, is it a contusion or is it infiltrating? I heard it. Chest tube. There's a chest tube present. Okay, this guy actually, yeah, that's the one. Okay, so you guys see it over here. You have this white line that comes out. This guy actually has two. Okay, the other one is down here. Everybody see those? So you have a white line on all the tubes that ever go into your belly or into your body, okay, that are radiopaque so that we can actually see where they traverse on imaging. All right, what about this one? Okay, is it cavitation? Is it pleural effusion? Or is it some sort of edema? What do you think? What do you see? Where is it normal? Can you tell the difference? Okay, who wants cavitation? Who wants pleural effusion? Who wants some sort of edema? Who wants normal? We're going to go to break right now. Just answer the question. Which one do you think it is?
It might be a cavitation, the top corner, maybe?
It's not normal. I think we can all agree on that. It's not normal, right? Okay. Maybe we can agree on that. You see this area of white here? Okay, area of white here? That is a edema or an infiltrate, or most likely a confusion. Okay, there is no cavitations, there is no pleural effusions. Does everybody see that? Right? So, see how it's more like whiter than the other areas? He may actually have a little bit over here too, but this is the main area of confusion. Because he actually, I think, has refractors on that side. Okay. Please take 10 minutes. Come back refreshed. Cool off. Actually leave this room. Take the lung tissue, right, or along the lung fissure lines, okay, and or ribs shadowing from behind, okay. If you're going to have a cavitation, it's actually going to be a full circle, okay, a nice thick walled circle. Okay. All right. So moving on to pneumothoraces, we can have spontaneous and or reason, like a stab or a puncture or broken ribs, okay? In terms of what it looks like on x-ray, okay? This side, the right side, you have those lung markings, the normal lung markings going all the way across. And then this side is tiny little bleb or blip of tissue that looks like the edge of the heart is actually the lung, and the rest of that is air. Okay, the lung markings do not go all the way out like you see on the other side. Okay, you may see a little tiny fluid air level, okay, on the claustrophrenic angle. Okay, it may have a little bit of a meniscal sign if there's blood, okay, or if there's a pleural effusion along with a pneumothorax, okay? And if it's blood plus air, it's a hemopneumothorax. All right. On this side, you can actually see it actually gives you the nice arrow sign. It's nice when radiologists do that. Okay. You can kind of see where those lung markings just stop, and the rest is nice clear black along the ribs. Okay. It could be small. But normally when we actually see it on x-ray, it's greater than 30%. It will follow gravity unless they've had a pleurodesis, which we'll talk about, okay? So if they're upright, the air will be more up, superior, okay, on the apex. If they're laying down, you may not see it, or it may be more like this, where it's all the way surrounding the lung. Okay, just depends. All right, what do you see here?
Some lung markings right above.
Pneumothorax, okay. Small apical pneumothorax. You can see this white line right here, kind of shadowed by the ribs. Okay, that is the actual lung, and everything above, all this black up here, is air. Right, so you can see where those normal lung markings come up, and they just kind of stop right behind this rib, and then it's nothing. Okay, so same on this side. The line is right here, kind of traversing over that rib. Okay, and everything above is air. Okay, so you can see the difference. Okay. What do you see now? Chest tube. Okay, it's finished. So now you can actually see all of that lung tissue go up as far as about right here. Okay? Alright, diaphragmatic hernias, they can happen normally through a Volcadex hernia or something like that, or traumatically, okay? You won't necessarily have any lung markings because whatever intestines or organs are up into the chest, it basically pushes the entire lung up. Okay, so their lung on this side is this tiny little speck up here, and the rest of that is intestines and stomach, and their spleen is most likely up there too. On CT, okay, this is their right hemidiaphragm. Their left hemidiaphragm is all the way up here. Okay, so you have their stomach, their spleen, their kidney. So, alright. Atelectasis. Atelectasis is next. This is a kind of a minor effusion, or not a minor edema. Okay? But it's not necessarily caused by, like, really a lot of pathology, like pulmonary edema. You know, you see that with CHF, you see that with certain other diseases. Atelectasis is a lot of the times due to being sedentary. Okay, they're laid up after surgery. They're a little bit fluid overloaded, okay, but they don't have a history of anything. It basically, you can kind of see it isn't infiltrated. It is patchy. Okay, but it's basically the lung is collapsed. Their alveoli are collapsed. And so it looks like they're filled with fluid, but they're really not. Sometimes it's really kind of think of it more of a collapsing of the alveoli. Okay, they're just not using it. Okay, there's going to be some edema around it. There's going to be some fluid around it, but mostly it's going to be that collapsing because they're not taking that deep breath. They're not recruiting that lung tissue, so it's kind of collapsing and just staying shut. Okay? When that happens, it traps that fluid in that alveoli, meaning they're more prone to getting pneumonias. Okay? So this is why after surgery we want them to get up. We make them use what we call an incentive spirometer, which helps recruit that lung tissue. Okay, by taking that deep, slow breath, helps pop open all those alveoli and helps prevent pneumonia. Okay? So this is more so a sedentary and or post-op type of picture. Can it happen in other things? Sure, but I really want you to know just for post-op people. Okay? All right. Cardiomegaly, this should be a review. When you have pericardial effusions, it can make it look like the actual heart is bigger. This is where ultrasounds and CTs come into play. But you can see after pericardiocentesis, you can actually see like actual depression of that sac where that fluid was. Okay. All right. What can we do to help diagnose stuff in the lungs? First off, we have the sputum analysis, and we want to try to get a deep cough and or brushing or washing after a bronchoscopy. Okay, this really helps determine what type of bug is actually in the lung. Okay, what type of infectious or fungal, whatever it may be, whatever we find. Okay, it can also be valuable for detecting lung cancer, although that's not necessarily our first choice. We can do skin tests, so tuberculosis screenings, cytoplasmosis, and coccidioidomycosis. Okay, we can test the skin, just like, has everybody had a TB test before? Everybody at least should have it like once, right? Where they, use the subdermal or Q kind of infusion of that whatever solution. Okay, same thing for histoplasmosis and coccidioidomycosis. Okay, when we're looking at chest CT, so CT chest with IV contrast is the gold standard. Okay, cornerstone of evaluation for chest pathology. Can we get away with sometimes just doing a chest X-ray? Absolutely. But if we really want to know the down and dirty gritty of like what's happening in the lung, normally our first choice and our gold standards right now are chest CTs with IV contrast. Okay? We can do MRIs. They are very slow. They take a long time. But if we have something that is a tumor that is invading into the chest wall or into the vertebrae or into the spinal cord, we do spinal structures, the superior sinus or the Pancoast tumors, which we'll talk about. Okay? Do you remember those from POM? Have you had that in POM yet? POM's a junior class, right? Yes, do you remember Pancoast tumors in POM? No? The tumors that are really high up in the apex? Okay, we'll talk about it later on in this actual lecture. But if we are suspecting that or any invasion, an MRI is what we need to do. Okay, and then we have PET scans, and really remember we're looking for the detection of like the spread of the cancer when we're doing PET scans. Okay, we get a radionucleotide into the blood system, and then it goes after those high metastasizing cells, which cancers are by definition high metastasizing cells, okay? And then it'll show up as hot, okay? You see hot, okay? That way we know exactly where it has spread in the body. All right, other things, these are mainly going to be done by either medical or the surgical critical care intensivist, or the, interventional pulmonologist or the interventional radiologist. Okay. Endoscopies, we can do laryngoscopy or bronchoscopy. Okay, if we're looking for a vocal cord or really upper trachea type disorders, okay, that's going to be a laryngoscopy. We're doing bronchoscopy that can actually go all the way down into the smallest alveoli that we have, smallest bronchioles that we have. Okay. We can take brushings, we can take biopsies with both. Lung biopsy, we either have a needle or a surgical biopsy. Okay. When we do mainly needle, it's going to be either by bronchoscopy or by CT guided through the chest cavity. Okay, from the outside in. And then when we do surgical biopsies, again, we put a camera in there and look, and actually take core biopsies versus just a needle. Okay. Pleural biopsies, again, that looks at the pleural lining. We can either do that through percutaneous or a VAS, a video-assisted thoracoscopic surgery, okay? Or we can actually open the chest and take those biopsies. Mediastinoscopy, I have actually never seen one. It would probably be more so done by either the IP, IR, or those cardiothoracic surgeons. Okay. We have two different types, cervical and anterior, and that's just the approach. Okay, where they're actually going to enter to get into the mediastinum to check, like, and do biopsies of the mediastinal lymph nodes or tissues. Okay. And then we have, like I said, the video-assisted thoracoscopic surgery, the VATS, which is laparoscopic thoracic surgery. So when you laparoscopic or diagnostic diagnostic it's too hot for you to talk. The camera that goes into the belly, right? Camera that goes into the chest. Same difference, same cameras. It's just what different type of area that we're going into. All right. Okay. Talking about the diseases of the pleura. Most common benign pleural problem is a pneumothorax. Okay. Pleural effusions and primary pleural tumors are really uncommon. They're really rare. Okay. But when we have those pleural tumors, they're most likely going to be from a metastasis from something else. Okay. When we have pleural disease, the main common symptoms are pain and dyspnea. Okay, it's going to be sharp, it's going to be worsened with those respiratory movements, often inhibiting inspiration. So they're going to be breathing kind of shallow. They're not going to want to take a deep breath. Remember that visceral pleura is insensate. Okay, so when you have actual pleural pain, most likely not going to be from the lung, unless it is a lesion or a mass that started in the lung and is now invading into the pleural cavity, or the pleural lining. Okay? Alright, so pneumothorax. I'm going to go into more of the pathophysiology of it, how to treat it, versus what it looks like on x-ray. Okay? Simply, it is the air between the lung and the pleural space, or pleural lining, in the pleural space. Okay? We have simple and tension. Okay? Simple mainly means closed, meaning there's something coming out of the lung, but the outside rib wall, okay, the pleural lining is intact. Okay? So this is going to be your spontaneous. This is going to be pretty much your spontaneous. Okay? If you have a penetrating or open, you have that sucking chest wound, meaning that there's a connection between the lung, the lining of the chest wall, and the outside air. Okay, when you breathe in, it actually sucks air into the chest. Okay, instead of it closed, you suck air or you breathe air, and it just accumulates in the chest. It doesn't have anywhere else to go. Okay, when you have that tension physiology, okay, that's when you need to emergently do a chest decompression with a needle thoracostomy, okay, and then a tube thoracostomy after that. Alright, these are all the different causes of pneumothoraces. Lots of different types, lots of different causes. Okay, you just have to be aware of them. Okay. The biggest one for spontaneous is the Marfan's. Okay, you're going to have the long, lengthy person. You may have Ehlers-Danlos syndrome. Okay. All right. Again, chest pain, dyspnea. Okay, if you start to have tension, you're going to be diaphoretic. You're going to be cyanotic. You may have weakness. Okay, you may have hypotension, which leads to that cardiovascular collapse. Physical exam, again, tachypnic, so breathing fast, but shallow, tachycardia, deviation of the trachea away from the involved side. Okay, so if you have a tension pneumothorax on the left, everything is going to be pushed to the right. Okay, if you have it on the right, everything's going to be pushed to the left. Okay. Decreased breath sounds on whatever side is involved. Hyperresonance, because you don't have that lung there, you have air, okay, and then decreased vocal firmness. All right, labs and imaging. What do we do? So arterial blood gas, these are great if you can do them. Really helps differentiate between like hypercapnia and hypoxia, or both. Okay. We want to do an EKG. We're looking for those axis deviations, non-specific ST segment changes, and the T-wave inversions. In terms of X-rays, okay, the textbook answer is PA view upright. That is the textbook answer. Okay, but they have to be stable, and they have to be able to travel to the radiology department. Okay, that is them doing a PA view, so going from the back to front. And they want it on exhalation. So they basically tell you to exhale and then take it. Okay. I have never had a stable pneumothoraces that I could do that on. Okay. Normally we just do a AP view, and we have them inhale, and it works with this. But textbook answer right now is for spontaneous pneumothoraces, so not trauma, but spontaneous. Okay. And they're stable, they can go to radiology department to do a posterior, anterior, and lateral chest x-ray. What's more commonly done is the anterior posterior view on inhalation in the ED in their bed because they're unstable for whatever reason. Does that make sense? Okay. Chest CT with IV contrast is now considered gold standard. Okay, it'll really differentiate between a large bullae and a pneumothoraces. Okay, and a lot of times if the pneumothorax is so small, we will only really pick it up on CT. Okay, like I said, it really only shows up on x-ray if it's more than 30%. If it's less than that, we may not actually see it on x-ray. All right, for treatment, depends on what type it is. Okay, if it is simple, they are small, stable, and asymptomatic. We observe them in the ED for about 6 hours. We take another x-ray. If there's no change, we can send them home with decent follow-up. Okay? If it is small, apical, and symptomatic, or they have mild enlargement but not greater than 30%, either on the second x-ray or a CT, we admit them to the floor and we give them supplemental O2. If it's greater than 30%, okay, on the first image or any subsequent image, then we admit them and put a chest tube in. Okay. If it's tension physiology, we needle decompress them emergently because it's only temporizing, and we do it at the second intercostal space, mid-clavicular line. Okay, so here. Okay. New guidelines are coming out that we can do it at the fifth intercostal space, mid-axillary line or anterior axillary line. Okay. Because on vests, right, that's where it's open. Okay, it may not be open here. And with people with large musculature, okay, it doesn't actually, a lot of studies have shown that the little needles that we do for needle compression actually doesn't reach inside the chest cavity when we do second intercostal space. So a lot of recommendations are now going to the fifth intercostal space, but textbook answer is the second. Okay. If they are in traumatic arrest or extremely unstable, and we need to get that air out, we can do what's called a finger thoracotomy or a finger thoracostomy. Okay, we're only doing a small little hole, putting our finger in, releasing that air, but basically waiting to put the chest tube in. Okay, well, someone else is putting and getting that chest tube fit together. We just put a finger in, release that air or blood so that we would get their physiology back. And then we put in a chest tube for definitive treatment. When we have sucking chest wounds, okay, we do that normal chest seal, and they get a chest tube. Okay, but we have to close off that hole that's sucking in air first, or at the same time. Okay, we want to stop that inhalation of air into the chest. Okay, but we want to make sure that we can still are able to suck that other air out. Okay, if the air becomes persistent or the pneumothorax becomes persistent, sometimes we have to do what's called a pleurothesis, which we'll talk about in a minute. Okay, what do you see here? Rib fractures, what side? Right side? Air where? Okay, a little bit of pneumomediastinum, but other people can't hear where you're pointing. Sub-Q, yeah. Look at all that sub-Q air. That is what sub-Q emphysema looks like on x-ray. Okay, it's outside that chest wall. And then you have rib fractures here and here, here and there. What are these guys? What do you think those are?
Previous surgical on the spine?
Hmm?
Or you say had surgery on the spine?
Nope.
Okay.
Previously I had surgery, but not on the spine. Where do you think that is?
Soft.
What part of the chest? Sternum, right? So they had a median sternotomy. Okay, most likely open heart surgery. Those are wires, surgical wires, that actually keep the sternum together. Okay? So when we do a median sternotomy, median sternotomy, they basically use a saw and go up the middle of your sternum and crack your chest open that way so they can get to the heart. Okay. You can do that as well in a traumatic situation, but most of the time we'll go in from the left. All right, what do you want to do about it? What do you want to do about all this? Did anybody catch the pneumothorax up here? Or were you just kind of in awe of the subacute air? Oh, it goes all the way up his neck too. What do you want to do with this? Chest tube. Yeah, absolutely. Just because the air is not within the chest anymore as much as it should be, it basically decompressed out into the subacute tissues. Okay? As well, yes. Surgery consult, sure. They're going to be most likely admitted to the surgery service. Okay? But yeah, they need that chest tube.
Need an adult.
Alright. You have a stable patient who has suspected spontaneous pneumothorax. Which of the following imaging studies of the pneumothorax is most likely to be visible?
Yeah. Alright.
Who wants one? Who wants two? Who wants three? Who wants four? Good. It is three. Textbook answer: posterior, anterior chest radiograph on expiration. Okay, because they are spontaneous pneumothorax and they are stable. If it was just an unstable pneumothorax, it would have been two. All right. Moving on to pleural effusions and infiltrates and why they're different. Okay. When you look at pleural effusions, okay, you have the normal lung and then you have the fluid around said lung. Okay. An infiltrate is actually within the lung tissue itself. So if you have a patient with pneumonia, that fluid is going to be purulent. If you have a patient with pulmonary edema, the infiltrate is most likely going to be serous. And if you have a pulmonary contusion, the infiltrate is most likely going to be blood. Okay? But bruised to the lung. Okay? Alright, so this is fluid inside the interstitial spaces. Okay? You're not really going to have those meniscus within the costophrenic angles. Okay? You may, if it's both infiltrate and a pleural effusion. At that point, I would probably get a CT to try to differentiate the two. But this is just interstitial diseases, okay? So pneumonia, contusion, if they have some sort of inhalation injury, so say they were in a house fire and they breathed in a lot of smoke, they're going to have an inhalation injury, okay? People who are in septic or sepsis, and ARDS, acute respiratory distress syndrome. And one thing that the PANCE loves to ask about is the trolley, okay, transfusion-related acute lung injury, really follows transfusion, okay, of blood. For whatever reason, that person has a transfusion reaction, and you have a flash pulmonary edema, and they don't do so well. So treatment for that is to stop blood and do supportive therapy. Okay. Also, if you, sometimes we can't help this, but rapid expansion of a pneumothorax, okay, it can actually cause that lung to go into a pulmonary edema, a flash pulmonary edema as well, and not do so hot. So we, again, there's not really much we can do in the way of preventing it, right? Because we just put it to suction and it re-expands on its own. But it's something to watch out for anytime we put somebody on a chest tube with active suction. All right. Going through the different causes and what to look for physiologically wise. Okay. You have someone who has increased pulmonary vascular hydrostatic pressure. Okay. Look for heart failure or mitral stenosis. Okay. If you have somebody who has a decrease in the vascular colloid on-tonic pressure, think hypoproteinemia. Okay. And kind of so on. So increase in that capillary permeability due to inflammation, pneumonia, pancreatitis, sepsis, increased or decreased intrapleural pressure, atelectasis, again, just being sedentary. Lymphatic drainage, you're going to have carcinomatosis or a cryothorax. Okay. Basically, you're going to have like cloudy, milky fluid within the chest, so that effusion is going to be more milky. If you have ascites, or rupture of that pancreatic pseudocyst, you're just going to have transdiaphragmatic movement of abdominal fluid. And then any rupture, vasculature, or lymphatic structure with traumatic injury. Okay. So what do you need to know about this? I'm not going to make you know, like, what vascular coli and oncotic pressure is. That's calm. Okay. But if I were to ask you kind of, okay, what physiological stuff causes, or what would cause, let me say this again. For congestive heart failure, what do you expect it to do on the lungs? Okay. For atelectasis, what do you expect that disease to be actually doing in the lungs? Okay. All right. That is a cryothorax. Yep. Gross. All right. Pleural effusions. Okay. So this is, again, not in the lung, it's around the lung. You're going to have that meniscus sign. Okay. But you're going to have decreased respiratory extrusion, meaning they're not, because they don't have a lot of space for that lung to actually expand. It's going to be harder for them to take a deep breath. You're going to have diminished breath sounds, dullness to percussion, versus if it's air, it's going to be tympanic. You may have that friction rub, okay, localized tenderness. Yeah. Again, looking at chest radiographs, okay, a little bit of fluid, 300 to 500, you're going to start seeing that blunting. These two are more so with the entire pneumothorax, so that's a lot of fluid on both of these. Okay, but both of these are actual a type of pleural effusion. Okay, this guy is laying down, and or the entire chest has some sort of fluid around the lung. You can't see any of the lung markings. Versus this top one, we have that meniscus. It's still there, right? But the lung is very, very compressed up until the apex. Again, chest CT with IV contrast is the gold standard. We want to really be able to evaluate that fluid within the chest. Okay, we may see septations. We may see that it's blood. Okay, we may see a whole bunch of different stuff on actually the image within the CT, and helps us differentiate what it is. So, when we talk about pleural effusions, normally we talk about that fluid being either transudate or exudate. Okay? Normally we want to try to get at least 20 mL of that fluid to do studies on it. Okay, we do that by getting a thoracentesis and drawing out some of that fluid and what we're ordering. Okay? To include a serum total protein, LDH, glucose, gram stain, and a culture of that fluid. When you have congestive heart failure, liver failure, okay, basically when your total protein content is less than 3, when your LDL or LDH, greater than 3, if your LDH level is less than 200 and your specific gravity is below 1.016, okay, it's going to be transudate. If it doesn't meet those criteria, then it is an exudative, and mostly it's going to be cancer. Okay? Or pneumonia. So when you think exudative, think cancer, pneumonia, infection. So you really need to know the content of the labs of what the actual fluid makeup is to really figure out what it is. Okay? All right, what do? Okay, we have interventional radiology. They can place percutaneous drain via CT guidance. Okay, this is specifically for loculated or that septated type of pleural effusions. When we get that pathology back of that fluid and it's malignant effusions, or we know that they have some sort of cancer and it is a malignant effusion, we draw off fluid for strictly palliative type care so that they can breathe and re-expand the lung. A lot of times, if it's recurring, we can put in a closed chest tube, a small one for 24 to 48 hours, draw off that fluid slowly so that we prevent that flash pulmonary edema. And then we do a pleurothesis, again, which we'll talk about in a minute, to try to scar that lung up against the wall to prevent further effusions. When we start talking about empyemas, I know we haven't talked about what an empyema yet, but it's basically an infected pleural effusion. It's walled off. It's basically a nice abscess of the pleural space. Okay. We treat those by thoracentesis and/or we can do chest tubes. If it's really, really bad, we can put 2 chest tubes in, and we can kind of do what's called an irrigation, where one tube has fluid going into it, and the other tube has the washout going out of it. Okay. We can do surgery, either the VATS or the open thoracotomy to try to wash it out. And again, the decortication, going in and trying to take out that abscess rind of the chest. And then doing pleurothesis to try to get that lung to stick so it doesn't happen again. When we have a hemothorax, we want a large bore chest tube. Okay? So when it's simple fluid, a small bore or a pigtail is okay. But if it's blood and it can clot, or if it's really, really thick, gross, purulent fluid, we may need a large bore, so 32 to 36 French chest tube. Okay. Now, pneumothoraxes are different because it is lymphatic tissue or lymphatic fluid. Okay, so it's pretty similar to that malignant, but all we do for that one is really a low fat diet. Okay, if it's so bad that they're asymptomatic, we could do a thoracentesis to try to draw off that fluid, but most of the time that's never going to fix it. The fix, the definitive treatment, is a low fat diet. All right, how do you do a thoracentesis? Okay, it's basically a needle decompression, but under sterile procedures, normally done at bedside, and normally we have them sitting up, kind of bending over a pillow. Okay, same thing, kind of like when we were doing those LPs or the lumbar spinals. We want to open up that rib cage so that we don't hit ribs going in. We have them sit up so that the fluid is dependent and it's not just spread along the entire thorax. It's gravity help us. We can do it under ultrasound if we need to. Most of the time we don't need to though. Okay, we go down pretty low. We anesthetize the area, we sterilely prep and drape, we insert the needle under negative pressure, meaning this is not one that you just insert the needle and then try to draw out. As you're actually inserting the needle, you're having positive or negative back pressure on that needle until you hit that pocket of fluid, and then it's going to fill up with either fluid or air. We collect or drain whatever fluid we need. Again, slowly. Once we withdraw the needle, we put a bandage on, we send that fluid to analysis or to pathology, and then we do a post-procedure x-ray to make sure that we did not cause a pneumothorax. All right. Closed chest tube thoracotomy. If it is a pigtail, normally surgery and/or IR is going to place these or critical care. It's a little bit different than just putting in a normal chest tube, which you guys can do. Okay. If you're doing a normal chest tube but with a smaller tube, that's fine. Pigtails are under the Surgury technique, which we'll talk about in the next block. So these are not pigtails. These are either small bore chest tubes or large bore chest tubes. Okay. So identify or position the patient. Normally you have them whichever side hand up and kind of leaning away from that side so you have a good open area. We identify where we want to actually insert it. We anesthetize the area. Again, sterilely drape and prep. We'll go over chest tubes and EM as well as during the ATM lab. Okay. As well as the next block. We either leave the tube in, okay? That is technically a pigtail. It's a very, very small bore tube. If we are doing just a thoracentesis, we drain off as much fluid as we can. We take the needle out, put dressing on. If we're actually going to leave a tube, we dress around it. We make sure that we are padding underneath the tube so that it's not pressing up against the skin and causing irritation. And then we end it. Okay. And again, post-procedure x-ray, making sure that we did not cause pneumothorax. Closed drainage. There's 3 different collection type of things for closed drainage. We have the gravity bag. Okay, so it's hooked up to the end of the tubing, and we just allow gravity to pull that fluid off gradually. Not as common. Okay, we see that more so with the malignant effusions, that we want it to come off slowly and give them gradual relief, because they can empty these bags on their own. Okay, so more so for palliative type care. When we have collection jars, they are basically, think of it as a huge like vacuum seal. Okay, like when you have a little blood tube, right? It's under vacuum. That's how the blood gets into the tube. Same thing with these. These are under a vacuum pressure, so when you actually pop the needle in, it'll draw from that negative pressure, pulling that fluid out of the chest. And then we have the atriums, which are most common in traumas and or post-surgery. Okay, it again has positive pressure. Okay, we can hook it up to wall suction, or we put this fluid, this water, basically sterile water, into this part of the atrium, and it does not allow air to go back up into the patient. So we call it a water seal. So it's not necessarily on suction anymore. So there's 2 different ways we can use an atrium, either on suction, positive suction, or the water seal. Okay, but basically we're making sure that air cannot get back into the chest, but then we can actually measure how much is actually drawing out or coming out of the chest, whether it's blood or fluid or whatever it is. Okay. The atrium is most common if we need a chest tube. All right. 5 more minutes and then we'll take a break. Let me see what number slide we're on.
41.
41. Okay. I'll leave it up to you guys whether or not you want to continue or not. Pleurodesis. Okay, so now we're finally talking about pleurodesis. Okay, this is what we use to actually either manually or chemically irritate the lining of the pleura enough that when the lung gets re-expanded, it sticks to it. Okay, it scars into the chest. Okay, what does this do? It helps prevent spontaneous pneumothoraces. Okay, if the lung is constantly adhered to the chest wall, most likely not gonna collapse. Okay, and for those effusions that are chronic. Okay. Most common chemicals that we use are either talc or doxycycline. Talc is the most common. Okay, we can either do this by making a slurry and instilling it up into the chest tube, kind of leaving it there and seeing if the lung will re-expand, or we can do it through operative actual means, meaning either a vat or a open thoracotomy. Okay. Manual or mechanical is actually going in, and it's really brutal. Basically, you take like a Brillo pad and scrape the entire side of their pleural cavity, so their pleural lining, and we make it raw, and then we re-expand the lung post-surgery, and it scars. So it's not necessarily using any chemicals, we're actually physically hurting the lining of the pleura, okay, so that when we re-expand the lung scars into the chest cavity. Okay? Yeah, it's brutal. I've seen it once and it was like, ugh, it made me hurt. Okay? So there's 2 different ways that we can do pleurodesis. Alright. Which of the following conditions is not associated with a transudative pleural effusion? So if I'm saying not a transitive, it is then exudative, and what's the most common exudative? Cancer, malignancy. Yeah. Okay, all the other ones can be a transitive one. All right. How are we doing?
Not well.
Not well. Okay. This could mean, because the other lectures are pretty long as well, that this may take up some of the review time. Because then you have 9 lecture slots. Normally my 9th lecture is the review. We can either do more now and get this over with and have a full review, or this may run into a review time. Up to you. Who wants to just push and get this done? Okay. See you. I'll see you next week.